All right, good evening and welcome to Feet Forward. My name is Chris Martin with the Illinois Podiatric Medical Association. Welcome to an rainy October edition of Feet Forward. With us tonight is podiatric physician Mike Wood, who is has a practice in Lansing in Chicago. Big shout out to the 10th Ward and all of our viewers out there. It's good to have you on. Tonight's topic is about foot surgery, and for all you Feet Forward fans out there, and I know you're plenty out there, we do typically talk about prevention. We try to give you tips on how to avoid seeing surgeons and how to avoid invasive and expensive and sometimes painful procedures. But we know that sometimes that can always be avoided. There are car accidents, like the patient you were telling me about this morning, that you had to treat. There are chronic diseases that create problems that can't be prevented sometimes. And then there are other kinds of things that crop up that we'll talk about, from bunions to hammer toes. But before we get into that, tell us a little bit about your surgical practice, and tell the audience about your how you're a second-generation podiatrist. We want to know about that.
Thank you, Chris. You know, I'm a second-generation podiatrist. My father started his practice in 1970 out of the Ohio School of Podiatry. He started his practice on the east side back in '85, and we were able to practice together for about 10 years. He's retired 6 years now, and it's not what he's doing. It's where he's doing it. He's got a fishing pole surgically attached to his hand now. But I've always been thankful for that. And we practiced on the east side and in Lansing, in Illinois. Mm-hmm. And our practice centered around surgery. As we were going through that together, oddly enough, my nephew seemed to latch on to what we were doing, and he's a proud second-year student at the Scholl College at the Rosalind Franklin School. So it seems to be continuing as we move forward into the future.
The line of succession of Wood podiatrists will continue. Rest assured, Eastsiders, there will be podiatric physicians in your neighborhood from here until a long time, right?
Amen. But thanks for having me on, and,
sure.
And I really enjoy talking about foot surgery, and I hope there's people out there who like hearing about it. Foot surgery is different than a lot of the things that we do to prevent problems, in the sense that by the time we have made a decision for foot surgery, most of the things that we do to provide relief have failed. Mm-hmm. That it is rarely one of the first things that we would recommend. There are exceptions, of course, but the fact of the matter is that there's usually a variety of things we can do. Some of the things we're going to talk about today, though, are structural deformities of the foot. A structural deformity of the foot requires us to be very diligent in regard to appreciating why we're having symptoms with this. Because, for example, if we have a bunion, and a bunion is a deformity around the big toe joint, mm-hmm. and it can look like a lot of different ways. But we want to know why we're having pain with it. Is it because of the fact that you're wearing shoes that are the wrong size? Are you wearing 5-inch pumps? Mm-hmm. Chris? And
I'm a 3-inch guy, actually.
Sorry about that.
I'm already tall.
But if we're doing the right things and we're still having pain with this, then our job is to give you information in regard to your treatment options. Mm-hmm. And they can vary from simply making custom-made shoes. Mm-hmm. You know, as bad as a bunion is, it is not a foot heart attack. It is not foot cancer. I rarely have to rush in with paddles and resuscitate the foot back to life because of a bunion.
Right.
So my job is to give information. Mm-hmm. The nature of a bunion can vary based off of the apex of the deformity. Sometimes the deformity occurs at the big toe joint itself, that within the toe itself, that there may be a deformity that either because of a trauma or injury, that the toe itself is now pointing more towards the second toe. Sometimes it's because of the fact that our foot type has allowed a developmental change that, with mileage, or age if you like to be so blunt, that we have eventually just walked into it, that at 10,000 steps a day, 7 days a week, 52 weeks out of the year, this is something that that has just crept upon us. Sometimes it has to do with the type of job that we have. Are we working a foot pedal? Are we on our feet for 12 hours a day? I don't have anything in my pocket to cure a 12-hour day on your feet, but we can usually do something to provide a great deal of relief for you.
Mm-hmm. So when someone comes in with a bunion, are you looking at sort of categories of bunions? Are there 2 or 3 common sorts of ones that you see a lot of, and you can tell, well, that's this kind, and that typically means this sort of thing? How do you sort of approach it?
Well, the vast majority of bunions occur around the great toe joint and usually involve where the great toe is either laying on top of or underneath the second toe. And we want to assess that. So we'll get x-rays. Mm-hmm. We'll take a look at you, both sitting and standing, and we'll diagram out exactly what we think is the most appropriate procedure. The most common procedure we do by far is a distal osteotomy, or a cutting and shifting of the bone more towards the great toe joint. Mm-hmm. And this is a very nice procedure because of the fact that it allows us to weight bear afterwards. We get excellent correction, and bone healing is usually accomplished within 4 to 6 weeks. There's usually a pin or a wire associated with it, because with that cutting and shifting, once we put the bone where we need it to be, we don't want that bone to move back before the bone is healed.
Mm-hmm. When you say weight bearing quickly, does that mean that the day after the surgery, the patient can, with a boot of some kind, walk around without crutches? Or
well, usually you get one of our Gucci shoes, and we'll allow you to walk on that the day of the procedure. Mm-hmm. Obviously, I don't want you taking a 6-mile hike.
Right.
And the first 3 days, we really want you to kind of take it easy for us. Mm-hmm. There'll be some antibiotics and some pain medication, but mostly we want you to take it easy during that time period, because the local anesthetic can still be in effect for a day and a half afterwards. Mm-hmm. And we don't want you to be overzealous on it at a time when you can't feel what's going on.
Right.
After the first 3 or 4 days, we'll get a dressing change in, and we'll see you back about a week or 10 days later. Mm-hmm. Stitches are usually out at that time. And we want protected weight bearing for that entire 4 to 6 weeks that the bone is healing, so that while we may be able to move you out of the surgical shoe by about 2 weeks, you cannot be barefoot during that entire 4 to 6 week process. Mm-hmm. If you are and you stub your toe or you drop a can of tomatoes on it, we'll get a chance to hear about it, usually at about 2 o'clock in the morning. And patients don't like making that phone call, and from this end it's no fun getting that phone call, so I try to keep you out of trouble as opposed to getting you out of trouble.
And with that break, we'll encourage people to call us tonight at the number on your screen. That's 738-1060. We're happy to answer your calls. If you are in need of a podiatric physician, you can see the website right behind us. That's ipma.net. Find the button that says Find a Physician. Type in your zip code, and you'll get 2 or 3 recommendations in your neighborhood, all IPMA members, that you can go set up an appointment with, and hopefully they will prevent you from having to see someone like as charming as Dr. Wood. Let's talk about hammer toes.
Okay.
But before we leave that, do you ever get a patient with bunions on both toes at the same time?
Oh, yes.
And if you do you typically recommend that the surgery is done at the same time, or do you stagger them?
It's a personal preference in regard to the surgeon. I find that my patients do better if we do 1 foot at a time. And the reason is because then you have one good foot to get around on, mm-hmm. and your gimpy foot. And so you're basically getting around on 1.5 feet. And
right.
Most people do fairly well with that. Mm-hmm. The amount of pain and discomfort afterwards tends to be significantly less, in my experience. Again, mm-hmm. It's a personal preference.
Right.
But at about, I tend not to put them closer together than 12 weeks. And that simply gives the patient a time to recover. And so when they start bearing weight, when we do the other side, that the side that we did surgery on is ready, willing, and able to handle its load. Mm-hmm.
Do you ever find a patient that had such a bad experience with the pain the first one, they're like, I don't want to go through that again. I'm going to put it off for 2 more years and just suck it up? You
know what? No patient comes to mind like that. Usually we're able to control pain.
Never treated me, obviously.
Yeah, exactly. And that gets us to patient selection and picking the right patient for the surgery.
But refer me to your neighbor, I'm sure.
Yes. But my typically patients are able to tolerate this very well. High degree of functionality,
Right.
some common sense. We don't want you watering the garden in the mud. We don't want you letting your dog sniff and lick at it or anything like that as you're healing. And we don't want you to do something because your foot feels good for a day, despite the fact that we're still in the acute healing process.
Right. Okay. Sorry for that digression.
That's all right.
Let's talk about hammer toes now.
Okay.
How are hammer toes different than bunions?
Hammer toes occur to the lesser toes. So the second, third, fourth, and fifth toe of the foot. And pardon me if I look at my hands. Doctors, podiatrists do that all the time.
I forgot our foot model tonight.
Exactly.
Sorry.
Well, I didn't want to take my shoe off. But what happens is that we get some sort of angular deformity with the toe, and it can occur in several different ways. The first way is that toe, as opposed to laying straight off the foot like this, is crooked and up. But it's not unusual, just with foot type and shoe gear, for that toe to start twisting around so that you get a multi-vector deformity of that toe. And that runs into problems with shoe gear because it starts hitting the top of the shoe.
Sure.
And sometimes we'll actually get the most intense pain, not at the knuckle that's hitting the shoe, but rather at the tip of the toe, because that tip of the toe is pounding into the ground. And on the bottom of your toe, you've got a nice fat pad, but at the tip of the toe, you've got a little skin and a little bone. And so it's like bonking your head 10,000 times a day into the bottom of your shoe.
Right.
So when we get a patient who has difficulty with this and is a surgical candidate, typically what's required, again, x-rays, and this can vary a little bit, but the most common things that we recommend is removing some of the arthritic bone associated with one or two of the joints of the toe to allow us to straighten that toe out. Now, because that toe has some degree of soft tissue memory of being crooked, the analogy I make, and coming from the 10th ward, I'm hesitant to make it here, it's kind of like a politician needing to go to jail to forget that they used to be crooked. But what happens is that we need to use a wire to hold that toe out straight so that soft tissue relaxes, so it remembers that it can belong. And at about 3 weeks, that wire is removed. Typically, that wire is covered. I'll tell patients tongue-in-cheek that if I didn't tell them they had a wire in their toe, they wouldn't know it. But it is a very predictable way to get long-term relief with these types of problems.
I'm sure all the politicians in the 10th ward have no idea what you're talking about.
You know what? I stand corrected.
So what kind of surgery is required to correct that deformity? And is it, you had mentioned arthritis in passing there. Are hammer toes typically associated with arthritis?
Yes.
Is that like a risk factor that you can look for?
Well, arthritis is a garbage pail term. If you're over the age of 18 and you've had any kind of life, I guarantee you, someplace on you, you've got a touch of arthritis.
Over 18?
Just think of the miles you put on your body at 18 and all the silly things that you've done with your body by the time you're 18. Women in the shoe gear that they wear, men in the sports or activities that they choose to engage in.
Right.
Maybe that's a little bit overselling it. But at some point, I'm a little hesitant to say that arthritis will cause it, but certainly it's a component of it.
Sure.
And usually, again, it's based off of foot type and activities and incidents that have occurred in our life up to that point, most specifically traumas, injuries, that type of thing.
Sure. Okay. So you go in and clean out the arthritic stuff, and then get to the business of the surgery then.
Correct. So we go ahead and we make a skin incision, and we'll go ahead and use a special instrument to remove that arthritic component. It's a small saw, and it takes off the end of one of the bones in the joint and allows us to straighten that out. Again, another instrument's used to run the wire, and then we close it up, and that's about it.
And what's the rehab and recovery time?
Well, with all bone healing, it's about 4 to 6 weeks. So that wire remains in there for about 3 weeks. Once the wire is removed, we're back into a regular shoe, typically, with probably a little splint on it, just to prevent additional injury. We don't want to be barefoot again during this time, but once the wire's out, we can begin getting it wet and begin increasing activity to some degree to tolerance.
And are patients typically sent home with a pain reliever of some kind, a narcotic?
Yes. I usually give them an oral pain medication, just depending on what their tolerance is. And this again is very well tolerated. We do more than one toe at a time on a foot. I would rarely do more than one toe on both feet at the same time. Again,
Right.
for the same reasons I gave before, just our ability to tolerate two gimpy feet at the same time is marginal. Okay.
And what kind of tips do you recommend for? Is there some advice you can give for preventing these, or is there really very little to do? And the tips you're going to give are just how to manage it afterwards,
Well,
or the
there's
pain
n-
beforehand.
this is such a, with the exception of trauma, these are such slowly oncoming deformities that about the best analogy I can make is the way that a pearl's made, just kind of a grain at a time. And at some point, though, it just passes a threshold, and this threshold causes pain. And if we make modifications and that pain continues, then we become more likely to be a surgical candidate. And those modifications almost certainly involve shoe gear. A pointy-toed shoe, a very tightly fit shoe, and it's not unusual to have a shoe that will go ahead and be a size or half size too small. That makes the difference.
Okay. We have our first caller for the night. Hello, you're on Feet Forward. How can we help you?
Hello, I was calling regarding the latest technology or medication with foot fungus, because I've taken medication and Pinlac, and it hasn't really seemed to work.
Okay. And this is for toenails?
Yes.
Okay, very good. Well, fungus toenails have a very poor history of responding to topical medications.
Okay.
One of the reasons is because of the fact that the fungus lives within the nail root. It is not that it cannot work, it's just that the amount of time and effort that's required to get a statistically significant chance of it succeeding is monumental. If you've used Penlac, you know, which is a fine medication, don't get me wrong, but you have to use it every day for about a year. And there's a process that you have to go about every 7 days, you have to remove it.
Right.
Women tend to do better with that than men because women have a history, usually more so than men, of putting on and taking off nail polish. So what I like to do is I like to, number one, make sure that it is a fungus, because a lot of dermatology, a lot of skin conditions require look exactly the same.
Right.
So
I've been under a doctor's care, and I stopped going because I don't have the insurance right now.
Yeah. So what we do is we take a specimen of the nail, make sure it's a fungus.
Okay.
Typically at that time I'd get what's called a liver function test or a hepatic profile, and what that does
Okay.
is make sure that we don't have any active inflammatory conditions of the liver.
All right.
And then my next step is to use an oral medication. I like terbinafine or Lamisil. You probably have seen this on TV. It's got a little mascot called Digger.
Yeah, Lamisil made me sick.
Oh, did? Okay. Well, if you can't tolerate Lamisil, that is, there are a couple other medications out there like Grispeg, and I want to say Sporanox, but I'm not quite sure how much in vogue Sporanox is. I haven't.
Those over the counter? or
Sporanox.
prescription?
No, these are prescriptive
Flukiel.
medications. I'm sorry.
Those are prescription medications.
And they do need to be taken with the physicians following you, because they're, if taken incorrectly or wrongly, they can cause a problem.
Now we had a couple podiatrists on Feet Forward earlier this year that offered. I think the caller asked about technology in fungus. There are a couple laser devices
Yes.
that are now on the market, and a handful of podiatrists around the Chicago area offer that. It's not inexpensive, but it's not medication based, and there's no liver toxicity associated with it either, like some of the medications. So that may be an option for you too, ma'am. But you'll have to find one of the podiatrists near you that offer that, and then
Yeah, that uses a YAG laser. It's a special type of laser that uses color, an ability to set a laser to a certain tissue level and is used to ablate that fungus. So that is a possibility. I think the verdict is still come see, come saw with that as far as what the final results are. But it is out there, and it's interesting to look at.
Yeah. All right, thanks for your call. We're going to finish up hammer toes first.
Okay. So getting back to hammer toes, essentially we've done the surgery, we've put in the wire, we've taken the wire out at 3 weeks, and then you're back into most of your shoe gear. Obviously, you have to be a little bit careful as far as your shoe gear selection as you move forward. I asked ladies to hold off on any high heels for at least that 6 week period, and to make sure that the shoe is appropriately fitted. To try to avoid that type of problem, to avoid the need for that type of surgery. If we're in too tight a shoe, that is excruciating. It can cause the toes to deform more and take something that might not be painful in an appropriately fitted shoe and make it unlivable, period. Right. And just as an aside, if we're in the wrong shoe, there's no treatment available that will make you symptom-free, regardless of the procedure. So if you're looking to get something done just so you can wear something extravagant, I would really take a moment to sit down and talk to you about your selection.
I'm sure Mrs. Wood has heard that lecture.
Oh, yes, indeed.
We're down to about 4 minutes, so I wanted to skip over plantar fasciitis and heel spurs because I want to talk about as disdainful as it is, amputations, because it's a very important and severe topic, and it's often sort of a last resort sort of surgery, but it's often a life-saving surgery as well. So talk about the common sort of context that exists medically when that's required, and how you decide, when and how to do it.
Well, amputations is I kind of put it in the category of one of these magic words. If I ever have to say the word amputation to a patient, oftentimes the patient stops hearing anything I say beyond that. And that's reasonable. I mean, that's understandable. We always like to try and have family around because of the fact that this is a life-changing moment. As a physician, I don't like amputations whenever I can help it.
Right.
But there are times when they cannot be escaped. Infections, loss of circulation, pain, things that are absolutely uncontrolled or untreatable by another mechanism. There are times when the tissue dies. When the tissue dies, it cannot come back. And it will serve as a source of infection for the healthy tissue that remains, and can potentially make you sick and threaten a greater part of the limb and even a life at times. Consistently, the most common type of amputation I need to do is on the diabetic patient. Diabetes, of course, is a ravenous disease. It affects Hispanic and African Americans at a 2-to-1 ratio to Caucasians and Asians. It hits them younger and it hits them harder. But the fastest growing demographic for diabetics in the United States right now is white females, 35 to 45.
Wow.
So it's going after everybody.
Wow.
Amputations occur typically because of a combination of poor circulation and an inability for the foot to have protective sensation. And what occurs is the foot sustains an injury, something relatively mild. Could be a blister, could be a cut, could be a scrape. If you combine it with a lack of an ability to feel the bottom of the foot, and the fact that diabetes also affects the eyes, the patient has a difficult time knowing they've hurt themselves.
Right.
So this trauma, this damage has occurred. An infection has an opportunity to get a head start, and the diabetic patient already has a somewhat compromised immune system, which means that the startup for the immune process is slower. So when we see these things, they're oftentimes a full-blown fulminant infection. And we try to avoid that. But when we go ahead and move forward with an amputation, it is with the intent of this patient having as normal a life as possible afterwards, to remove that source that is endangering the rest of their life, and ideally get them on a path of healing and getting on with enjoying the rest of their life and their family.
And that's why most podiatric physicians and primary care physicians are encouraging patients to take their shoes and socks off during a primary care visit or a chronic disease visit, so that the doctor can check the feet, especially if the patient has diabetes already. So that's very important. This has been a great show. We're out of time, unfortunately. We could probably do 2 shows on this. So maybe we'll have you come back in the wintertime. But for all those people out there who are looking for a referral to a podiatric physician, they can visit the IPMA website. That's ipma.net. Click on Find a Physician and type in your zip code, and you'll get 3 referrals. And we will see you next month with another edition of Feet Forward. Thanks
Thank
a lot.
you.